Thank you very much for joining the international webinar series of CAHO. I bring greetings from the consortium of accredited healthcare organizations. We are an organization committed to promoting quality, patient safety, and accreditation. Thanks, dear friends, for the excellent support that you are offering to this movement. Today, we no longer can call ourselves an organization. We have certainly become a movement to promote quality and patient safety. With proud privilege, let me welcome our moderator for the day, Dr. Reema Nadig. Dr. Reema, a doctor by herself, has completed her hospital administration. She is a very well-known senior clinician and healthcare leader with over 25 years of experience spanning insurance, hospitals, and medical devices. She is the co-founder, director, the group chief operating officer, and medical director of KITES, KITES, Senior Care, Serene Communities, and Senior Shield. Amazing to hear this. I'm sure there's lots to learn from her, and we'll be delighted to invite her to share her experience of the variety of work she's been engaged in. Thank you, madam, for taking the time and for being here with us. Welcome you to the extended family of this wonderful movement. Under her leadership, these entities are pioneering senior care in India through integrated services in rehabilitation, palliative care, and dementia care, along with senior living and health tech. A champion of innovation and patient safety herself, she is transforming elder care with tech-enabled, compassionate approach. We look forward to hearing from you. Please take on the session, madam. The stage is all yours. Thank you.
Great. Thank you so much, Dr. Joseph. Very happy to be here and part of CAHO today. I think today the focus we will keep on Dr. Rana and we'll talk about my experiences sometime else. So the topic that we are talking today is really, really fascinating and very important for these times. So it gives me great pleasure to welcome you all to the 56th edition of CAHO International Webinar Series, conducted in collaboration with ISQua. So I'm happy to be here for, moderating the session with Dr. Rana, a close friend too. So today's session focuses on topic that is increasingly crucial in our evolving healthcare. I'm sure all of you will agree, which is accreditation in pre-hospital care. While healthcare accreditations of hospitals and clinical institutions, are always being there, but the realm of pre-hospital care, which encompasses ambulance services, home care, and telehealth, is rapidly expanding and needs robust quality for framework of its own. And I'm sure you're all working on it. Among these, I think ambulance and emergency medical services form critical first link in the chain of survival. From the response time to the patient safety during transport and from personal training to infrastructure readiness, standards here can literally be the difference between life and death. And who better than to guide us through this than Dr. B.K. Rana, a name which is synonymous with healthcare quality and accreditation globally. It is an honor, Dr. Rana, to introduce you today as a speaker. Dr. Bhupendra Kumar Rana, as he is widely known as B.K. Rana, a luminary in healthcare accreditation, both in India and globally. Currently, he serves as CEO of Quality and Accreditation Institute of India, India's first private accreditation body in healthcare and laboratories, which has achieved prestigious recognitions like International Society of Quality in Healthcare External Evaluation Association and International Laboratory Cooperation. His earlier tenure as director and CEO in charge of NABH under the Quality Council of India helped transform national healthcare quality framework. Internationally, Dr. Rana has held up leadership roles with ISQua as expert, surveyor, vice chairman, chairman of Accreditation Council, and board director. He has also served as president of the Asian Society for Quality in Healthcare. He is a member of global organizations like International Society for Telemedicine and E-Health, International Alliance for Patients Organization, and has advised WHO, World Bank, and United Nations framework conventions in climate change and many other. I mean, I can go on and on. And the reason I'm reading from a paper is because I couldn't grasp all that he has achieved so far. So, pardon me if I'm looking like I'm reading through it. With 25 years of experience in standardization and external evaluation systems and a PhD in biochemistry, wow, along with advanced qualification in hospital management, his approach blends science, quality, and vision. And all of you, please join me in welcoming Dr. BK Rana as he takes us through the importance, scope, and future of accreditation in pre hospital care. Very happy to be here, and over to you, Dr. Rana. All the time is yours. Very happy to be moderating the session for you.
Thank you so much, Reema. Thank you so much for your kind introduction. It's really an honor for me to be speaking in a session which you are moderating. Really honor. Thank you so much for joining this. It really encourages not only me personally, but I'm sure that everyone who joined this webinar would get encouraged with the themes which you have just narrated. So thank you so much, Reema. Thank you, Lalu, for opening up the webinar. And I would like to thank CAHO and ISQua for bringing me here today. Um, Neither CAHO nor ISQua is new to me, I think. Since they were born, I am being affiliated with these organizations in different capacities. So it's really like coming back home for talking with the friends and colleagues, not some strangers. So thank you so much. I think you rightly mentioned, Reema, about the topic of the webinar is pre-hospital care, and I think it's very complex if you look at the total ecosystem of healthcare delivery system, and it's most challenging, I would say. And the field which you are championing at the moment, the care homes, is definitely one of the uh, component of pre-hospital care. Though they may not be fitting well into healthcare organizations, but the social organizations, and that's why they play a very important role as well. So thank you so much. Now I'll just try to took the floor for sharing what I have prepared for this specific webinar around this theme. And let me share my slides with you guys.
Thank you very much for joining the international webinar series of CAHO. I bring greetings from the Consortium of Accredited Healthcare Organizations. We are an organization committed to promoting quality, patient safety, and accreditation. Thanks, dear friends, for the excellent support that you are offering to this movement. Today, we no longer can call ourselves an organization. We have certainly become a movement to promote quality and patient safety. With proud privilege, let me welcome our moderator for the day, Dr. Reema Nadig. Dr. Reema, a doctor by herself, has completed her hospital administration. She is a very well-known senior clinician and healthcare leader with over 25 years of experience spanning insurance, hospitals, and medical devices. She is the co-founder, director, the group chief operating officer, and medical director of KITES, KITES, Senior Care, Serene Communities, and Senior Shield. Amazing to hear this. I'm sure there's lots to learn from her, and we'll be delighted to invite her to share her experience of the variety of work she's been engaged in. Thank you, madam, for taking the time and for being here with us. Welcome you to the extended family of this wonderful movement. Under her leadership, these entities are pioneering senior care in India through integrated services in rehabilitation, palliative care, and dementia care, along with senior living and health tech. A champion of innovation and patient safety herself, she is transforming elder care with tech-enabled, compassionate approach. We look forward to hearing from you. Please take on the session, madam. The stage is all yours. Thank you.
Great. Thank you so much, Dr. Joseph. Very happy to be here and part of CAHO today. I think today the focus we will keep on Dr. Rana, and we'll talk about my experiences sometime else. So the topic that we are talking today is really, really fascinating and very important for these times. So it gives me great pleasure to welcome you all to the 56th edition of CAHO International Webinar Series, conducted in collaboration with ISQua. So I'm happy to be here for moderating the session with Dr. Rana, a close friend too. So today's session focuses on topic that is increasingly crucial in our evolving healthcare. I'm sure all of you will agree, which is accreditation in pre-hospital care. While healthcare accreditations of hospitals and clinical institutions, are always being there, but the realm of pre-hospital care, which encompasses ambulance services, home care, and telehealth, is rapidly expanding and needs robust quality for framework of its own. And I'm sure you're all working on it. Among these, I think ambulance and emergency medical services form critical first link in the chain of survival. From the response time to the patient safety during transport, and from personal training to infrastructure readiness, standards here can literally be the difference between life and death. And who better than to guide us through this than Dr. B.K. Rana, a name which is synonymous with healthcare quality and accreditation globally. It is an honor, Dr. Rana, to introduce you today as a speaker. Dr. Bhupendra Kumar Rana, as he is widely known as B.K. Rana, a luminary in healthcare accreditation, both in India and globally. Currently, he serves as CEO of Quality and Accreditation Institute of India, India's first private accreditation body in healthcare and laboratories, which has achieved prestigious recognitions like International Society of Quality in Healthcare External Evaluation Association and International Laboratory Cooperation. His earlier tenure as director and CEO in charge of NABH under the Quality Council of India helped transform national healthcare quality framework. Internationally, Dr. Rana has held up leadership roles with ISQua as expert, surveyor, vice chairman, chairman of Accreditation Council, and board director. He has also served as president of the Asian Society for Quality in Healthcare. He is a member of global organizations like International Society for Telemedicine and E-Health, International Alliance for Patients Organization, and has advised WHO, World Bank, and United Nations Framework Conventions in climate change, and many other. I mean, I can go on and on. And the reason I'm reading from a paper is because I couldn't grasp all that he has achieved so far. So, pardon me if I'm looking like I'm reading through it. With 25 years of experience in standardization and external evaluation systems and a PhD in biochemistry, wow, along with advanced qualification in hospital management, his approach blends science, quality, and vision. And all of you, please join me in welcoming Dr. B.K. Rana as he takes us through the importance, scope, and future of accreditation in pre-hospital care. Very happy to be here, and over to you, Dr. Rana. All the time is yours. Very happy to be moderating the session for you.
Thank you so much, Reema. Thank you so much for your kind introduction. It's really an honor for me to be speaking in a session which you are moderating. Really an honor. Thank you so much for joining this. It really encourages not only me personally, but I'm sure that everyone who joined this webinar would get encouraged with the themes which you have just narrated. So thank you so much, Reema. Thank you, Lalu, for opening up the webinar. And I would like to thank CAHO and ISQua for bringing me here today. Neither CAHO nor ISQua is new to me, I think. Since they were born, I am being affiliated with these organizations in different capacities. So it's really like coming back home for talking with the friends and colleagues, not some strangers. So thank you so much. I think you rightly mentioned, Reema, about the topic of the webinar is pre-hospital care, and I think it's very complex if you look at the total ecosystem of healthcare delivery system, and it's most challenging, I would say. And the field which you are championing at the moment, the care homes, is definitely one of the component of pre-hospital care, though they may not be fitting well into healthcare organizations, but the social organizations, and that's why they play a very important role as well. So thank you so much. Now I'll just try to took the floor for sharing what I have prepared for this specific webinar around this theme. And let me share my slides with you guys. Webinar is pre-hospital care and accreditation in pre-hospital. So little bit on the organization I come from to set the context why I'm here and why I'm going to talk about this very specific topic. So I come from an organization called QAI, Quality and Accreditation Institute, a body with global recognition, as Reema mentioned in her introduction about healthcare recognition through ISQua, EEA, and for our laboratory accreditation through ILAC. And the most important thing here is this slide. In our accreditation program, so far, we have been very successful in covering the whole patient care continuum, pre-hospital, hospital, and post-hospital. And in addition, we are moving and emerging as a specialist accreditation body. So we have a vertical called Center for Accreditation of Health and Social Care, where we run accreditation program in healthcare. And if you look at this slide, I try to make it little more bigger to look at. So it's about the program which we have. They are basically organization-wide general program like hospitals, clinics, any ambulatory care facility, including dental centers, eye imaging, and so on and so forth. Transition care, hotels, green healthcare, patient safety standards, vision centers, which are the first contact for primary eye care specifically. They're also not in healthcare basically. And QA 7101 plus, which is based on ISO 7101, which is the first international standard in quality management system in healthcare, ISO 7101. And I'm very pleased to say that QI is the first organization in the world to start training as well as accreditation program on ISO 7101. And then obviously care homes, which Reema very likely championing for last couple of years. So in this scenario, the care homes and transition care actually also falls into a little bit of pre and post hospital care. Because when patients come out of the hospital, do not go to home, they go to the transition care centers, is post hospital care. But care homes, which are generic in nature, people staying, may require pre-hospital care. So they also have linkage to healthcare facilities to provide required care to their residents. Now, coming to some of the programs which are very specialized in nature, we develop standards for IVF centers, then home health care, dialysis centers, telehealth, emergency department in a hospital, stroke centers, medical transport organization, hair transplant clinic, and bone marrow transplant facilities. So these are very specialized accreditation programs. And out of these, if you look at the telehealth, home health care, the medical transport organizations, they actually play a very significant role in pre-hospital care. And we are in the process of developing a new standard for headache clinics. Very specialized headache clinics program is coming up. So looking at the pre-hospital care, we have home health care, then telehealth and medical transport organization. Very commonly people call it the ambulance service provider program, or in some of the countries also known as EMS, Emergency Medical Services Program. So different name, but considering that what it serves the purpose, we gave the name MTO. So if you look at this, it gives us a picture that how home healthcare has been. And I think when we developed a standard in 2017, to me personally, I was facing challenges from my own colleagues. And this is what is home healthcare you are working on to develop the standards for accreditation. But God forbid, unfortunately, COVID-19 came, and then people know what home healthcare is. And since then, I think not only in India, but globally, people know what home healthcare is. And similarly, telehealth. This standard was also developed during COVID-19 in March 2020, when Ministry of Health has actually released telemedicine practice guidelines for practitioners to adopt during COVID times. And MTO is the latest program which we have just launched a few months ago. So we have accredited over 150 healthcare facilities international recognition through ISQua Accreditation, which gives us global parity, nationally recognized by CGHS, equivalent to NABH accreditation for different sort of hospitals, centers, and imaging facilities, and couple of clients across not only India but globally. For laboratory accreditation, we are the second largest in India after NABL, and we provide medical lab accreditation program, biobanking, and again, very happy to say QI is the first, not only in India, but in couple of countries. So we were the third in the world when we launched this standard for biobanking, and then international recognition through international laboratory accreditation cooperation, giving global acceptance of the results of the laboratory accredited by QAI. Over 160 laboratories and biobanks. We are present in 12 countries at the moment. So present is global and increasing. This is our gold seal. Now coming to the pre-hospital care. So now you understand why I'm here. We are an accreditation body. We develop standards for improving quality and safety, putting standardization in the center for any healthcare organization, and including social care. We are not just restricting to healthcare. So we call it Center for Accreditation of Health and Social Care. So like care homes, vision centers, these are actually more social than healthcare, though they provide healthcare solutions to the people. So in pre-hospital care, which may be referred to the medical needs, assistance provided at the individual's place. It can be anywhere. It can be at home. It can be at a place of temporary living. Wherever the patient or people need it, it need to be provided there. And it is also linked with any medical assistance which is provided to individuals even before they arrive at any hospital, or for that matter, any other healthcare facility, any other type of healthcare facility where a person can get the medical services. Is a very critical component when we talk about the healthcare ecosystem, particularly in emergency situations. It is very, very important to look at, because the whole aim should be to reduce the morbidity and mortality. Why? Because there are a lot of challenges in reaching out to the hospitals in time, and also during the transport from place of accident or incident or happening to a medical facility. It takes time, and sometimes it takes a lot of time. So what happens during that transport when patient is moving from a place to another place? So do we have that system to make sure that the care which is delivered during that time is timely, it is provided by a skilled workforce, and it can be anywhere, and home, at elsewhere, and then taken care of. So in principle, it says that right care at the right time, at the right place, by the right people. So these are 4 rights. So if we take care of this, and I think this makes a lot of difference for the outcome of the patient when the patient is suffering from a specific ailment. And as I just mentioned, it can be at home. So there is a home care, which can be sought by the qualified home care delivery organizations, whether it is a nursing professional or is a clinician or any allied healthcare professional to provide the relevant care. It can be any other place of presence, that is a home care. If not, then telehealth. And telehealth, again, by the side of a river, by the side of a beach. If you're eating, you can call a provider and seek and take the consultation. And obviously, in case where you can't reach out, it's beyond a teleconsultation. It's beyond to seek a home care. You need to go to a healthcare facility. And for that, you need a service provider, an ambulance service provider, a medical transport organization who understand your need and take care of you and take you to the right place for the further evaluation and treatment. So if you look at the history, and not long, but in just 2019, just 6 years ago, on May 30th, in the 72nd World Health Assembly, which is the largest conglomerate of the global leaders by WHO, they made a resolution. And resolution means a decision, the firm decision on emergency and trauma care, which is aiming to those countries which have, limited resources, and even those countries which are high resources, but still they have a lot of challenges to ensure timely care for actually ill and injured. Why it was? It was because it was estimated that more than half of deaths in LMICs result from conditions that could be treated with pre-hospital and emergency care. So I think that is the underlining the thin line of the care that we should be working on. It may include injuries, trauma, infections, acute excess of accelerations of cancer treatments, the patients with diabetes and other non-communicable diseases, and also very commonly with the complications of pregnancy. I'm very happy to see some of the ambulance provider when we were developing standard, and they were sharing stories, how they help the mother to deliver baby, even during transport, even not reaching to the hospital, but during the transport, and very heavily with good credibility because of trained and skilled people. And emergency medical services, EMS, is an essential element of UHC, universal health coverage, which is again a global agenda for almost every country. And India is also a signatory to that universal health coverage agenda of the World WHO. So how all these needs, how these situations and combinations of the situations, whether it is a home or away from home, linked with accreditation. We try to address some of the issues, may not be all issues, but try to address issues through accreditation. So, and mine mean last 20 years of being into accreditation. Accreditation is a beautiful tool for taking care of many things, which otherwise are not. So, as a definition in healthcare, because in ISO the definition is little different than what it is in healthcare. So, I took it from ISQua. EEA is a formal process by which a recognized body, which is an accreditation body, usually a non-governmental organization, assess and recognizes that the health or social care organization meets applicable, predetermined, and published standards through an external evaluation process. So there are three keywords. One is an organization of usually non-governmental, uses an external evaluation process to evaluate an organization against a set of standards. So the standards play a very important role in any of the accreditation system. And more so, the process of evaluation become more critical because it's not just the standard which are important, but the organization using those standards for evaluation become more important because how they use it to make it more credible process of evaluation becomes important. And that's why the role of ISQua EEA comes in, because ISQua accredit the accreditation bodies. So we call ISQua as an accreditor of accreditation bodies. So like, QI is accredited by ISQua EEA as an organization, in addition to standards for hospital and home care as well. So if we take this definition along and when we look at what problem was, so we started in 2017, and first standard we started working on home care. And this was my actually vision of having a standard for home care in India, because learning something from the West, we learn many things. So I learned this from the West, that there are insurance given in home care. There are how things are moving, and recognizing a fact that the aging population is increasing in India or globally as well because of advancement in science, medicine. The age is becoming more. So aging population require care at home. So that's become the standard for choice when we started QAI. And now this is standard in the second edition. This is ISQua accredited standard. And second standard we developed during, not second, but related to this theme of pre-hospital of telehealth services in 2020, which is under revision at the moment, is for telehealth services, which include basically the doctors who are actually providing, plus a digital platform, or if it may be a standalone platform for providing services. It can be a hospital-based telehealth solution as well, where there are things as per TBG guidelines in India and elsewhere. So they need to be formed and used. And the third standard related to pre-hospital is a medical transport organization, which is just a year back we launched as first edition in 2024. So I just try to give a snapshots of how these three different standards looks like. Not much different, but they are different. They are not similar, they are different. Terminology looks similar, but the content may not be similar, maybe different as well. So if you look at the home care standard, in this context, it looks like that it takes care of the whole organization in terms of the governance and the management through human resources, facilities, and so on and so forth. But what is difference in this standard than a hospital? Is a structure, is nature of a provider. In a hospital, you have the place, the permanent building. But in home care, they are a permanent building from where they actually operate their head office, their the leadership, even their technology platforms if they have any. But the service is not within that facility. Services are given at home of the patient. So the care provider has to visit the home of the patient. And for that matter, when we talk about facility and risk management, it covers not only their own offices, but also covers the home. How you ensure that when the care provider visit a home, it's safe for them as a care provider and also for the patient. So these things makes the structure of the standard different, the content different than a hospital care. Similarly, there are limitations. There are limitations of on the home care services. Though now I am aware that there are even ICUs are being set up at home, dialysis are being done as at home, cancer care is being given at home, but they need to be within the regulatory requirements of individual countries. If you look at the telehealth, yes, care remains care, but it's totally different standard because it's not covering everything what you cover in a hospital. Has a limited role because it's through telecommunication, whether it's audio, video, or a digital platform. It can be any system, but whatever system is used, it need to meet the regulatory requirements of telemedicine practice guidelines in India, and there are many other countries who have their own national guidelines and policies to practice. What is different here is, say, for example, how you identify a patient. When patient comes to hospital, you physically see patient, check everything, come on, how you identify patient here, and how patient identify the care provider. That is also equally important. It's not just the one way, it's both way. Both the entity need to identify. So there should be a system of identification of patient and our doctors also. How the prescription. So here there is no procedure basically. Is that mostly the prescription of medication, and that also with limited medication prescriptions, how you prescribe, how you transcript this to the patient site. All these things are actually captured in this standard when we talk about medication prescriptions and safety. We talk about digital health application because if you use a platform, a technical digital platform to all of you may be aware there are a lot of platform they are providing telehealth services, and some of them are like Practo is one of the largest in India, which is accredited by QAI. Even hospital-based telehealth, we have accredited one hospital in Dubai for telehealth practices. So these makes the standard different than what digital tool you're using. In case there's a video system, how you ensure the data captured is confidential, saved for the time you need to save it for that duration. There is no vulnerability to data safety and security. Similarly, when we look at even some imaging, now there are increasing use of even teleradiology, telepathology, and so how you make sure those things work as it should work in a hospital care. Now coming to the third step, which I will be taking in more length to explain the importance is about medical transport organization, commonly known as IEMS or ambulance medical services. Similarly structured, but again, contents are not similar inside. It's not sufficient time for 30-40 minutes to capture the entire standard, but I try to take the glimpses of the standard. But what is important and different in this than a hospital standard is some of the aspect, because it's an ambulance, it's a vehicle, and it's connected to a hospital which is providing care in time to come. And maybe the same hospital is also running this MTU services and dispatching it also. There may be some other standalone mobile ambulance service provider who actually ferrying the patient from the site of incidents or occurrence to a hospital. So it's in the middle of the whole ecosystem, from the place of a patient to a hospital, which is going to provide the care. So it's remain in the middle. So how they connect with each other, when is required, who calls it, where to call, how it best dispatch from the location of ambulance, whether it's a hospital or any other place, how it get activated, how it reaches, how it is the chain of communication. The whole chain of communication need to be captured. We cannot afford to break the chain of communication in between, whether it's to the hospital or to the patient, either way. And then it's about a very special chapter, we call it CAT. I like that, but CAT is communication and transport. So how the whole communication amongst the whole ecosystem, from hospital to the ambulance service provider, or ambulance service provider to hospital to the patient, and all this, the networking communication goes while the transport is in. So, and how you maintain all those vehicles and all those things comes into this. This is standard, very, very unique. So this standard is actually framed in 10 chapters, as I just showed to you all, which has comprise of 77 standards divided into 397 measurable criteria. So what I try to give you the glimpse of chapters, can't go down there. So in governance and leadership, basically, there need to be a governance structure which actually is responsible for delivering quality and high quality and safe services to the providers, to the patients or the people who are seeking those services. So it's not different than any organization like a hospital. You need to have an organization to run this. The MTO, regardless of its complexity, it may be a fleet of just 2 ambulances, maybe fleet of 5 ambulances, maybe fleet of even 100 or even 1,000 ambulances. There are organizations running more than 5,000 ambulances in their network. The state governments running the network of thousands of hundreds of the ambulance services. Transport mechanism is affected. So there need to be a formal structure, and that structure need to be completely guided by the management. They need to be really look at as like any organization in healthcare. So to ensure that the organization is completely equipped with the required resources, whether in terms of the human resources, in terms of financial resources, or in terms of any other resources required to completely and diligently execute the services this organization is aimed to deliver. Looking at the second chapter, which is human resource management, and the most important is actually this chapter, because the humans who run the organization need to be credible, competent, skilled. So they that include all type of people they work for with MTO to make sure that delivery of quality, patient-centered, and safe care to their patients. And here it again includes like a hospital. I think doctors, nurses, allied healthcare professionals, maintenance staff. More here, maintenance staff is for ambulances, the vehicle maintenance, rather than the facility maintenance, and obviously the drivers who actually drive these ambulances. So the management is actually need to provide safe physical environment for staff to work in, like any other healthcare facility, which is free from any harassment or accidents. It's whosoever is manning, driving, and executing the services from these service. Facility and risk management, yes, it is different than not exactly same as a hospital, because as I just mentioned, it is different. It is a facility. It may be a permanent physical facility. It can be a permanent facility for ambulance to park in, because there are different models being used. There are fixed asset model where the hospital has ambulances are running it. There are MTOs, commercial MTOs who are running it, and there are state governments under PPP running it. So there are different models and modalities. There are systems where ambulance serves a specific area. So they are parked at separate places to deliver services to that specific location. So they may not be get parked at the same place all the time. So wherever they are parked, that facility also included in the standard. Planning, management, and delivery of care. Yes, how the services are planned, how they are managed, and how they are delivered to the needy. And it also required assessing the risks to pupils' health and safety during any care or treatment premises, whether from the head command centers being run or ambulances being parked, any equipment being used need to be safe and available in required quantities, and need to follow all laws and regulations. Like for vehicle, obviously, the pollution control certificate, the license for this, and all those things, everything is captured in the standard. Information management system, yes, it's little complex, very important how the information is actually collected, transmitted, stored, analyzed, utilized, and retrieved in time to come. And also required a sound document control system. Any policy, any procedure, any process which is documented need to be standardized, need to be controlled, which makes sure is available to the right people at the right time in the right place. Yes, CQI is a continual quality improvement. It's a master chapter, I say usually, because it drives the whole organization. It captures the essence of the entire organization's objectives, the visions, and the mission of organization. So it should have an effective quality system in place. It should have defined indicators, for example, satisfaction rates of patient, staff, and even downtime of equipment, staff attrition, and so on and so forth. Even some non-clinical quality indicators, particularly like vehicle dispatch turnaround time. People expect, oh, I get in 10 minutes after I dial it. Do you get it in 10 minutes? It is, determined by the provider. Staging at hospitals, breakdown time for vehicles, for equipment, medication procurement, and very important because it's a moving facility and medications are stored. How they are stored? Do they have a proper temperature, for storing the specific medication? All these things are defined, and also process for clinical audit. Patient assessment and care is as soon as the vehicle reaches the patient site, how the patient is assessed and the needs are identified to take it to the required place of treatment. So, and the services to be defined, documented response and deployment plan to be in place, patient transit. During the transit of the patient, how the communication flows from the vehicle to the place of care where patient is going to be landed, and also what is done during transport. All those things are taken care of. Specific standard put in about safe obstetric care. As I was mentioning, there were deliveries made during transport, safe delivery, I would say, by skilled people. So if that happened, how you take care of the newborn until the site of the hospital. And also process for care transitions. Care transition means even one hospital to another hospital, home to hospital, hospital to home, and different types of situation during transitions. Rights and education, nothing new, as it can be a clinic or a hospital. Patient has certain rights. They need to be communicated, they need to be documented, and they need to be protected. Medication management and safety, yes, I think they don't go then different than the hospital, but yes, the criticality is when it is in a vehicle, moving vehicle or in park vehicle. How to ensure the integrity of a specific medication. Those processes need to be in place. And obviously other things like prescription, transcription, and preparation and dispensing and administration goes by the law as required. So it goes through all those regulations, not different than that. But yes, CAT is different. CAT is totally different because this is the heart, I would say, heart of the any ambulance service provider. So we call it ambulance medical services, specialized field where specialized healthcare needs are addressed through well-defined processes in emergency response center by emergency professionals. An important aspect of EMS include early detection of any emergency, immediate response, reporting, on-scene care, en route care, and transfer to appropriate definitive health. So this middle statement is very, very important. How you identify, and that's why the skill is required for those people who are manning that ambulance and going to the patient site. And then emergency response command control center, ERCCC. This is a need. This is the requirement in the standard. You need to have a ERCCC which has all the logistics place, whether it's technology, whether human resources, whatever you need to control that for everything, starting from receiving a call to dispatch and then monitoring the whole movement of the vehicle during entire time. So this ERCCC actually is the heart of the ambulance service provider. Safe and effective ERCCC include the process of call handling, triaging, dispatching, closure of calls, analyzing, and reporting to the teams as appropriate. And then ensures ambulance are properly maintained. So all these things done through ERCCC, which is the critical component of any ambulance service provider. Coming to the end of the standard is with the hygiene and infection control. Obviously, whether it's a moving facility or a fixed facility, it's equally important. So all the policies and procedure for infection prevention and control program need to be in place. There need to be a policy in place. People should be trained on those policies and program so that they can practice this. And obviously, the facility, the ambulance itself need to be ensure that they are properly clean, disinfected, and sterilized for those things which are required to be done across the medical organizations. Think about you have 750 or 1,000 ambulances and how you really do that. So now coming to the linkage between accreditation and patient safety. People talk about patient safety, and everyone actually in healthcare is really working towards patient safety. So what is the link? As patient safety is defined in Patient Safety Action Plan by WHO a few years ago, is a framework for organized activity which creates cultures, processes, procedures, behaviors, technologies, and environments in the whole healthcare delivery system, which is consistently and sustainably lower risks, reduce the occurrence of avoidable harm, make errors less likely, and reduce impact of harm when it does occur. It's a very strong, very powerful statement given for patient safety. And so it captures the essence in the center of the patient safety. So if you look at culture, the processes, procedures, behaviors, all these are part of the standard for accreditation. In all 10 chapters, you will find the integration of these 6 pillars of patient safety embedded in the accreditation standards. And that's why standards for accreditation really help in improving patient safety. I will not go for the accreditation process. Anybody can read it on our website and can go through it whenever required. To support organizations, we do deliver the training program on different standards, including obviously these standards. We also need to have experts, not only in specific areas like this MTO service provider, but also which are trained on standards. So we do also conduct special assessor training courses from time to time to provide trainings to those we need as an assessor. So anybody interested can be in touch with QAI website or social media to get to an update. We have defined qualifications. I won't go in detail in there because of our time. So what is the progress so far? I'm very, very happy to say, that the government is very much interested. So Department of Health and Family Welfare, Government of Karnataka entered into MOU with QAI for accreditation of their 108 Arogya Kavach. They call it 108 Arogya Kavach ambulance service in the state. They run 750 ambulances. So far, they were running under PPP with a provider, but now they have decided to run it its own. So they have set up the command center and all these things. So we have signed an MOU, we got the work order, and they have started preparing and getting their staff trained across 31 districts of the state of Karnataka. So this is something which I'm very proud of, that government has come out with such an idea to improve their ambulance services. And Shalby Hospital in Ahmedabad also applied for accreditation. I think the assessment is already completed. And there are other several providers with the larger running 1,000 and 2,000, 5,000 ambulance service fleets. This takes time for training and process documentation. So they are working toward it. And in time to come, we expect a couple of providers to join QI accreditation program. This is my statement. I says that people blame quality as poor quality. I says quality never sleeps. It's not to be blamed. Its practitioner does. So the practitioner need to be blamed, not the quality. Thank you very much for giving me this opportunity, CAHO and ISQua. Thank you very much, Dr. Reema, for agreeing to moderate this session. It will not have been better person than you who have been into home care. You are into home care providing, as well as into care homes and many other healthcare facilities. So once again, thank you very much, and thank you everyone who are participating in this special webinar. Thank you. Back to you, Dr.
Wonderful.
Neema. Thank you.
Thank you so much, Dr. Rana. I think it was very, very insightful. And first of all, I'll start that congratulations seems to be appropriate right now for your breakthrough into the new forums of accreditation. I think, all the laurels to you. Very, very beautiful. And I loved your last slide too. Quality never sleeps. Because I also believe so that quality is only, it's a strive to excellence. Accreditations are only providing us the guide rails. It shows us our report card on a regular basis, helps us course correct, and ensures that we are delivering the care that we exist for. You know, so that is beautifully placed, and your depth and your span of your experience and expertise. I think it is mind-boggling. I'm sure all the participants will also agree with me over here. It was beautiful to hear you and the various new things, and very, very important for people in healthcare that we have to remember that healthcare goes beyond hospital walls. You know, whether it is the ambulance at the start of every touch point becomes very important for patient journey. It is just not from admission to discharge. It is pre and post also, that is very, very important. So thank you so much for enlightening us, and it was a very beautiful session. I would maybe for the next 5 minutes, probably if anybody has any kind of questions, you can please unmute yourself and ask Dr. Rana directly. In case there is, you can type it out. I can read it out for you. No problem. One of the questions was what is MTO? So I took the liberty of answering that. Correct me if I was wrong. Medical Transport Officer. Right.
Organization. Yeah.
Right. So maybe I will start with one question that I have. In case anybody comes up with a question, it will be, I know you can please put it on, but in the meanwhile, I will ask Dr. Rana one question. I mean, you as a accreditor, I'm sure there will be people when they come to you, they would be very confused that, there's so many questions that are being asked to us. Why is it so difficult? How do you kind of manage to bring all this together and ensure that they are there not for just the stamp purposes, but would continue to strive with quality?
Thank you so much, Reema. I think this is wonderful question. I think one of the most difficult question to answer, but it is important. And I always believe in practice rather than showing through a piece of paper or a certificate. So I always, advocate that use standards for improvement rather than just going for accreditation. You do it practicing the standard. One day you will think, okay, I am having everything now. Let's apply and get a certificate. That's good. But people actually go the other way around. They're looking for the certificate first. So the whole intent changed. The whole intent changed. So what we do basically, we are very we try. We may not be successful what we try to do, but we try to engage with our partners. The accrediting agent, the clients which we have, and also try to understand is something which we can add value to the organization. Is saying something that through the standard, but there are some certain standard. I can say now even standards for accreditation exist in India for around 20 years. There may be many standards still people don't know. So forget about how they will be implementing in their organization. So if you go to a hospital, we do not expect, yes, there are 100% compliance, but there should be reasonable compliance to the standards. But when you see the compliance is not there, I'm sorry, I was just visiting a hospital the other day. In a laboratory, the whole box is filled with the needle and syringes, the whole box. And the blood is spilling around. And on top of that, most of the needles were recapped, right? An accredited laboratory, accredited laboratory,
Yeah.
accredited
Yeah.
hospital. That gives me that where are we heading to? So I would say better not to get accreditation, but actually start practicing the right thing.
True.
When you still start thinking, yes, I have practiced, I know, I will mind this. That's why that the picture I showed you, patient safety in the center, the culture. People ask how you measure the patient safety culture in the organization. I said, this is the culture. If you go and see this type of situation, there is no patient safety culture. There is no staff
Correct.
safety culture. So I think this is something which we as an accreditation body need to understand, taking the feedback during standard development, standard revision. But unfortunately, we do not get much feedbacks also. So I think everyone, every stakeholder need to come forward, be critical, give suggestions, whatever it is. Then only things will change. Thank you.
Correct. Wonderful. I think also it has to be, I think quality is something that is top-down driven. It has to be believed. And, everybody, quality is not the quality department's job. It is everybody's job.
Everybody's job.
Yeah. So I think I have three questions over here. And before that, there is one, I think most of them would have this question is, as far as the ambulance accreditation is concerned, how do you balance emergency to following the protocols and documenting, etc., etc.?
Good question again. I think you are putting me into very hot speed, but very relevant. I think this is something which actually had to pay attention to. See, when people say, "Oh, I don't have time because there are too many patients rushing," so you treat 10 patients and harm 7 patients out of those, versus you treat 6 patients with good outcomes of 6. Which one you would prefer? See, this is the question
So,
I will ask.
yes,
So you are taking care of all 10, but 7, 8 are harmed because of that rushing thing. You are not documenting properly. In emergency, I saw emergency. One call is coming either from the patient or another colleague and writing the files. You cannot manage such things. So I
right.
think that is very important. The managing the job which you are supposed to do. So we can't just, but on contrary, we understand there is a lot of workload, but in the guise of the workload, we cannot harm patient by either writing the
Absolutely.
wrong treatment or wrong patient or wrong anything wrong, which is very
Yeah.
much preventable. That is the crux. Things which are
Yeah.
preventable, avoidable, should be avoidable and prevented.
Wonderful. I think it adds accountability to everybody. Everybody goes to the right thing. Super. So now there is a question by Mr. Swaminathan. Can it be integrated with JCI or NABH or any other accreditation?
Why not? Why not? If you are a hospital, for example, accredited by NABI, JCI, or any other agency for that matter, they're all similar, following the practices, and you are also running your ambulance services, definitely there will be many chapters you already have. You have to just link it with this standard. Okay, for this, refer to this, for this, refer to this, and rest will follow. Which is not there in those standards, you can write those standards policies, and then you are off to go.
Wonderful. I hope Mr. Swaminathan, you got your answer. There's one more question. I think this will be the last question probably by Shalom. What is the criteria for enrolling for accreditation? This is a
Okay.
KSA-based pre-hospital company.
Okay, good. Please send a mail to us. I have written the email ID. We'll
Right,
send you the
yes.
information brochure, application form, copy of standard. We are giving free copy of standard, PDF copy free, complimentary. Anybody interested in any of 21 standard which we are more than happy to give you a complimentary copy. Please do write to us for copy of MTO. We will be happy to do. And then you will be explained about the process and all these things.
Yes. Any other questions? Okay, there's one more question. Can you tell what is the minimum number of ambulances needed to apply
There is no
accreditation from your
minimum number
organization?
defined. It's up to you to define. You define one minimum or 1,000, we are there for you.
Amazing. Very nice. I think we don't have any more questions coming up. Maybe I'll wait for another 30 seconds in case there is. Anybody can unmute and ask.
How many
Amazing. I
centers
think,
are
sorry,
how many
yes.
centers are already accredited, Dr. Rana, sir?
Hello.
Yes, how many centers are accredited already?
MTOs. I think one is going to be, first is going to be accredited just in few days.
Okay, that's good.
And there are around 5 and 6, the bigger one, bigger one, running 100,000, I mean 1,000, 2,000, they are in the preparation.
Wonderful.
Amazing. Excellent. So I think probably we are coming to the end of this beautiful, amazing, very, very informative and insightful session. Thank you so much, Dr. Rana. It was a pleasure moderating this session. And of course, again, amazed by your depth of the knowledge and expertise that you bring in as far as quality is concerned. I'm sure all the participants over here would have, got the useful tips from you. Thank you so much, Kaho, for inviting me today to moderate the session. And best of luck to everybody. Thank you so much. It was a wonderful time I had today.
Thank you so much, madam,
Thank
and
you.
thank you very much, Rana sir, for that wonderful session. We finished on time, and we just have, some work to do. We really would like to honor you for the wonderful presentation. We have with us our finance chairperson, Dr. Naren Sehgal. I would invite him to hand over the certificate to Dr. Rana. This is a virtual certificate. You've been a champion, and we've learned a lot from you, Rana sir. We are together in the Patients for Patient Safety initiative as well, and to bring out some other aspect of the journal that we jointly have. Tomorrow, the next edition is also coming out. We have about 13 articles in that, so we are hoping by December we will get it indexed. Thank you, and I hand over to Naren sir. Over to you, sir.
Thank you, ma'am. Good evening and congratulations, Dr. Rana.
Thank you, sir. Nice to see you again.
Yeah. Sir, 2 years back, I was part of one of the angel investors and a company who was going to start ambulances the way we have Uber and Ola, and they applied for some amount of fund. And I, being from the medical community, it was put on me to assess and allow or disallow the funding. And I asked a very simple question from that owner, that how are you going to get so many ambulances? Are you going to buy? Because the fund which you have asked for will not be sufficient for that. He said, no, I will tie up with the local vendors. I said, how will you then maintain the quality and safety of the patient, which is of prime importance according to me? He had no answer. No, sir, they will see it themselves. So this was the state, and it did occur to me, and I'm very happy to see that standards have been generated meaningfully. And as people realize, and as the ambulance companies or the transporters, they get into this quality mode, it will be a great benefit to the society, sir. Congratulations again, sir.
Thank you, sir. No, you raised a very important point, and we have some of the client in the discussion. They are aggregators. So they have, say, 5,000 ambulances. They don't own like Uber or even Ola or even Oyo. They don't own. So they ask, sir, how we will? I say, if you claim this QI accreditation as a blanket, then everything need to be checked. So you are responsible for ensuring everything is in place. If you want to use logo on ambulance, otherwise forget about those. You only go for those who really you can control. So it's very important. They can't just get with one right and then 9 are not correct. So that is something very, very important. And same thing goes with home care. You are operating in multiple cities. And that's why we become very cautious for some organizations. They claim QI accredited, but they are just in 2 or 3 cities. So we have to send intimation. No, cannot claim that you are accredited for entire country. Because patient will know about those. So I think these are some very important points. And thank you so much for your comments, sir. Thank you.